Good morning. I want to present our case of robotic assisted treatment of duodenal web, and you can see my presentation.
Yes, Mirko.
I try to enlarge. Okay. I don't see my presentation. Okay. This is one. This is a case of a robotic-assisted treatment of duodenal web. The first case treated in our department by robotic-assisted surgery. So we know very well all problem and incidence of duodenal atresia and associated malformation. The classification is type 1, 2, and 3, but there is the type 1 variation that is a windsock variation. So an incomplete duodenal web. And wider is the passage, and later there is possible to do a diagnosis in some infants and then children. So we present Alex, is a 9 years old boy that hospitalized a few weeks for gastroesophageal reflux treated with gastrotooth syrup. He had a frequent episode of abdominal pain, recurrent food-related vomiting, mainly nocturnal, with partially undigested material. There have improvement with slow eating and prolonged chewing. So we perform an upper GI, and we see this minus in the GI. So we think to do a AGDS, and we found this condition. So this is the web, the duodenal web, incomplete, with not so little passage. So the child continued to eat and grow, but the diagnosis is being performed at night here. We think that the best approach, minimally approach for this problem can be the robotics surgery. So the indication is for robotic assisted surgery, web resection, but surgery has been delayed due to multiple upper respiratory infection during winter. So he had also, and yet occasional postprandial vomiting continue at home. So patient position is supine in anti-Trendelenburg position, and we identify the web with a preoperative endoscopy with positioning of balloon below the incomplete web. So to have traction of the windstock and to see the base of the windstock. This is the trocar position. We prefer to put other two accessories 5 mm trocar, laparoscopic trocar. And this is the intervention. So we free, as Alessio Pidiprato showed before, we free the duodenum from the adherents. This is the traction of the right column, and we continue to the adhesolysis. Then, as mentioned by Professor Patkowski, we put inside no one but two traction because we're afraid for the eventual twisting of the duodenum during the procedure. And we put two traction, so to have a perfect line to operate. This is the opening of the duodenum. You can see the dilated duodenum, proximal duodenum. This is the mucosa. And we continue for a longitudinal incision. The individuation of the web. With the accessory laparoscopic trocar, we have the possibility to suck the bile, and so we start the resection of the web. We put, you can see, a jaguar to individuate the whole of the web and to have the possibility to see the medial part of the web. You know very well that the ampulla, the papilla olfactor, is in the medial part, and sometimes I have I see the papilla within the web, so I'm a little bit I'm afraid to down damage to the ampulla. So with the Jaguar, we had a perfect vision of the medial part, and we cut the edge from the hole to the lateral part in this manner. Then we put inside a transanastomotic tube. I understand that it's not uh, right now usual, but for school, this is our technique and put inside for fast feeding. Then we continue with double layer suture. We prefer in this case a double layer suture because it's 9 years old and we don't want problem after surgery for this of leak for these patients. And this is, I repeat, the first our case of robotic surgery of the duodenum. So we prefer to do a double layer suture. This is the first stitch for the mucosa. And we continue the suture with Vicryl 4O Vicryl, and then we perform the seromuscular layer with interrupted suture. This is the end of the anastomosis, an Mikulitz anastomosis. And we put inside a drainage for safety, but not always necessary. Sorry, but okay. This is the final picture of scares. So not so good cosmetic result, I think, and the drainage here. Then the post-operative course was good, has been good, no post-operative complication. In day 4, we started administration of fluid from the nasoduodenal transanastomotic tube. In day 7, with nasogastric tube and nasoduodenal tube is clamped, and he tolerates clear fluid very well. After 1 day, we removed the abdominal drain and nasogastric tube. We start feeding from the oral side, and in the day 10, we discharged in good general condition the patients. So the take-home message are incomplete duodenal web, although rare, should be considered in children with persistent upper gastrointestinal symptoms beyond infancy. Its subtle presentation often leads to a delayed diagnosis. Appropriate imaging and early endoscopic evaluation are crucial, and surgery is a valid option for treatment. We saw literature also the dilatation of the hole, but endoscopic dilatation. But for this patient, in my opinion, was not the right choice. Raising awareness among pediatric surgeons can reduce diagnostic delay, and given its precision and accuracy, robotic surgery may represent a promising future gold standard for managing this condition. Thank you very much.
Thank you, Mirko. Congratulations for your great surgery. I mean, today we've seen already 2 cases of robotic duodenal repair of malformation, and we will be seeing other 2 cases soon. It looks like a very common procedure, but I believe it's not. What the literature says about? Have you had a look at the literature recently?
Yeah, I thought that this is the first case of duodenal web excited by by robotic assisted surgery. It's a common procedure in laparoscopic surgery. I have found only another one case, but duodenal surgery has shown, and also in the future presentation by Alessio Pineprato, as a good idea to perform robotic surgery in duodenal problems, especially in children, in infants, uh, when you are able to have a good positioning of the arms of the robots. And I don't know now in newborn. Nevertheless, I think that there is a very good precision, so you can perform the entire intervention in a good manner with a 3D vision, and this helps the surgeon, in my opinion.
Sure. Other questions or comment from the audience? Otherwise, I think we can go ahead with Alessio Piniprato. He's going to show us, well, let's say a similar case, a robotic treatment of duodenal stenosis in adolescent patients with Down syndrome and previously treated Hirschsprung disease. Alessio, are you available?
Yeah, yeah, of course. Just a second, I will switch from the previous presentation. I have to say that it's similar. I mean, maybe the condition is the same as the one that Mirko showed just now, but the treatment was different. And can you see this?
Yes, we can see, and I'm going to ask Mirko if he's happy. We can carry on after Alessio with Mirella, so we can put together all the similar cases and make a
Yes,
sort of
yes.
discussion at the end.
Yes,
Okay,
I'm only afraid if Darius want to start his intervention and
of
uh,
course.
Paul Philippe is coming. I don't know, but I think it's good to go ahead with Alessio.
Okay, thank you, Alessio. Sorry.
5 minutes, okay? Just
Ah,
we scrub ourselves and then we will prepare the
okay,
patient, and I think 5 minutes we will start, okay?
okay.
Okay, so I think it will be, I wouldn't
Yes,
say
be prepared to be interrupted, Alessio, of
Yeah,
course.
of course. I'm very keen on this. So you've already talked about Down syndrome, previous surgery for Hirschsprung, male, adolescent, the same age of the previous one, which allows us to go quite easily with a robotic approach. He had a strange symptomatology with diarrhea, vomiting, and weight loss. So basically, we thought about a celiac disease, but even if he had normal blood tests, we scheduled an upper GI endoscopy that showed a duodenal narrowing, and this is the barium meal confirming this sort of venous appearance. And we did CT as we thought about sort of lymphoma or other oncological issues because he's got a Down syndrome with a higher likelihood of having hematological disorders, but CT was unremarkable. And therefore, we scheduled the patient for duodenal disobstruction. I was prepared for doing a duodenojejunostomy, but at the end, we did a duodenostomy. And the reason why we approached more or less the same disease as Mirko did with a duodenostomy is that we could not identify the papilla, and therefore we were not keen of doing a web excision confidently. So when coming to surgery, we saw already a few procedures addressing the duodenal space. I believe that in neonates, in adolescents, in adults, every time we approach this area, we had to cochlearize perfectly the colon, the right colon. Otherwise, that area may become a real cause of mess. I want to underline that there's a caval vein over there, which is waiting for our error and mistakes. And the older is the patient, the less likely is that you can recognize and differentiate vascular structures from more intestinal ones. So we spend enough time to be 100% sure that we are not pulling portal veins or we're not pulling on the major biliary tree structures, and that we are isolating perfectly the duodenum, the first, second, and third portions of the duodenum. You can notice that the bands that are very thin in neonates and that can be freed with a gentle dissection in adults tend to be so thick that you have to keep watching on one side and the other side to avoid that some piece of loop will slip inside. As you can notice, we have accelerated up to 2 times velocity to make things more easy to understand and fasten shape. So the right column is being cauterized. This is the medial part of the duodenum. The difference between this one and the previous one is that you can notice the pancreas is only sitting on the medial aspect of the duodenum, so it is not the pancreas annularis. And at the very beginning, I thought it was a pancreas annularis because he had a Down syndrome, as I told. So that was higher likelihood compared to the previous patient that was not Down syndrome. This is the pancreas on the right aspect of the duodenum. So we keep on freeing it. And as we do not have any marking, we did not mark with an endoscopy, because once we did mark with a blue or with the black, and we ended up with diffusion of the mark, and therefore you don't understand anything anyway. So we are not used to mark from inside because it doesn't make things clearer, but sometimes make things more difficult than easier. So basically, we knew that the obstruction, the minus mark, was at the second portion of the duodenum. Therefore, we freed completely the duodenum up to the third portion. And basically, we knew that where the forceps is pulling, more or less that place should be the place of the obstruction. But at the beginning of this procedure, we did this mistake, which was to open. We thought that was the place of the obstruction, but at the end, we will understand that it's below the obstruction, because once we open it, we end up by having an upwards obstruction, and we will see it in a few minutes. And therefore, we had to do another opening upwards. The difficulty in finding the place of the perfect side of the obstruction is one of the most difficult part of the procedure during duodenal surgery if there's no dilatation. So basically, we inserted the forceps. We felt it was stuck in that position. So by opening and pulling, we feel that the duodenum is stuck, and therefore the stricture is in that part which is above our incision line, where the serosa looks a bit more clear, whitish, and therefore we had to do another incision upwards. And as we did not know where the papilla was, because we could not identify it with an endoscopy that was done previously, we decided basically to skip the web by doing a further incision upwards. It's not a diamond shape because it's not dilated upwards and small downwards, so there's no need to do a diamond shape incision, but we basically did only 2 transverse incisions. You see that it's very bleedy, and this is because the duodenum is always quite bleedy, but we know that this is above the obstruction. The other incision is below the obstruction, and therefore we just check if it's feasible to perform a lateral anastomosis or a duodenostomy. And the duodenostomy is done, as I showed you before, with 2 running suture on the posterior wall, the first one, and on the anterior wall, the second one. One thing that I want to underline, when we do running sutures with a minimally invasive, either laparoscopy or robotics is irrelevant. We do prefer to do locking suture.
Alessio, sorry, can I interrupt you right
Yes,
now?
of course, of course.
Yeah. Just we will start and then you will continue, and then we will come back, okay? So just to show you how it is, how we set up. So we are working across the table. So we are on the left side of the table. The patient is just at the border of the table. That's very important because you can move your instruments up and down freely. And the camera, the screen is on opposite side. So you are looking in transverse way through the operating table. So the landmarks are vertebra, the scapula. So the first optic trocar is just the posterior axillary line, about 1.5 centimeter below the scapula. Another one is halfway between the vertebra and the first one on the same level. And the third one that is usually the most difficult to place, it is just at the level of the axillaris fossa. And you have to go under the scapula, take the scapula up, and then enter the chest. I will show you in the moment how it is. So the first trocar is 5 millimeter with blind tip. Usually what we do, we put a small mosquito, and with small mosquito, we enter the chest, finding the space between ribs, okay, in this way. And then we take the 5 millimeter trocar. You can see that the trocar has a rubber around it. So you can move it freely up and down, and you can secure the trocar to the skin. So this is how we introduce the first one, just slowly. Okay, then we enter it. This is we have a mixed equipment. This is part of it is from Escula Farm, part from Storz. So we change the rubber into smaller one, as we have a 4 millimeter scope, a short one. That's very important to have a heating gas supply. We start with the pressure of around 6 millimeter of mercury, and then enter the chest and we check what's going on. Usually we ask our anesthesiologist for patient, because at the beginning there is a drop in saturation, but you can see that the view is really perfect, so we will even lower the pressure to 4. Obniżymy troszkę, dobrze? There is a slight drop in saturation, but not too much. Our anesthesiologist is not alarming us right now. Okay, give me a knife. So we make another 2 incisions, just for 3 millimeter trocars. Okay, give me the trocar. Right now we put the trocars under the scope control. Okay, the first one, another one. You can see that right now when we lower the pressure, you can see that the lung is moving. So we don't use a single lung ventilation. That one is usually the most difficult. You have to go, as I said, under the scapula. Just go back. Okay, just a moment. Okay, you can see that even too high. Somewhere here. Okay, so right now we will secure the trocars to the chest wall. This is the time for anesthesiologists just to stabilize a baby. Usually it takes 5-10 minutes to have a good ventilation. If not, you can proceed just with the fistula ligation and you can stop the procedure. But if the patient is stable, we can do the whole procedure. So it depends. It shouldn't be a problem with this baby, as the baby has no other malformation. The baby was born yesterday, so the lungs shouldn't be inflamed. As you remember from the bronchoscopy, the fistula was on the posterior wall of the trachea, above the carina. So we will check the moment the anatomy. And usually if the fistula is just above the carina, so we start with the dissection above the azygos vein. So the instruments I am working is a grasper and the dissector. Please switch the light off. So azygos is our landmark. You can see this is the distal pouch. You can see the vagal nerve here. Please go up. So you can see that it's really, this is the distal pouch. You can see how far it is going. I don't think that this is the upper pouch, but we will check anyway. So just we start with the blunt dissection, opening the mediastinal pleura. There are some vessels, small vessels. Can you move, możemy poprosić o ruszenie sondą. Can you move the nasogastric tube? This is what we start. We place the nasogastric tube into the upper pouch, just in case that we have any problem with identification. So you can see here is the upper pouch. So as I said, this is the distal pouch. So just I will try to find the space between the trachea and the distal pouch. It seems that I open the pleura a little bit too low, so I will go a little bit up. As you can see, the view is really perfect. This is the advantage of thoracoscopic approach. Sometimes the common wall is longer than you expect. Będę za chwilę potrzebował szapi, dobrze? You can see some space here. I will go from the other side. So I think that I'm almost around. Dobrze, mogę mieć to szapi teraz. This is the instrument that I prefer to use because it's less traumatic. But be careful with this dissection because it happens from time to time that you can open this very short connection with the trachea. Of course, it's not the tragedy, but sometimes it's a problem how to repair it. If you have a cuff tube, you can close it with the cuff tube. Będę potrzebował 10 cm, 8 cm 2,0 szwu, plecionka. So you can see that right now I'm on the other side, it looks. Dobrze, potrzebuję ten szef. Przytrzymaj mi trokar. Trokar przytrzymaj. A, połowę krótszy. Tak, tu na ten pierwszy łuk. O tu, bliżej, dobra, okej. Okay. So this is the way that we do. Of course, you can do it with the clip that is much faster. The only problem with the clip is that you have to use 5 mm trocar. Okay, so we are already around. Potrzebuję dissector.
Darius, can you hear me, Analysio?
Yes, I can hear you.
Didn't you do a transfix?
You can use a transfix. It's also the option, but for me, it's easier, just to do it in this way, because especially manipulation with the needle through the fistula, it's not easy. Of course, it's much more safer. So this is the very important point. As you can see, this is the sliding knot. So the long arm is on this wide, so I slide it right now. And before clothing, I need the, nie, potrzebuję tą, Shapi. That's very important because you have just only 2 instruments and you need just to position the suture just at the level of the fistula. So this is what I do. You can see that I will take the trachea into one side and then the fistula, the suture to the other side, like this. You can see. Okay, I have to take the pleura out. Okay, that's it right now. Okay, dissector. So just closing the sliding knot. Of course, you have to lock it like this. So right now the fistula is already closed. Panie doktor, jest jakaś zmiana w wentylacji? Okay, so the info from our anesthesiologist that the ventilation is perfect from the beginning. So nothing changed with the fistula closure. And this is also my experience that usually when you close the fistula, there is nothing that you can expect because already the stomach is full of the gas. So the pressure prevent more insufflation into the stomach. So it shouldn't be too much leakage. Okay, I will leave some of this suture for traction. Okay, so we are already done with the fistula. Right now, we will start with the dissection of the upper pouch. As you can see, still we are not using any energy. Poprosimy poruszyć teraz górną sondą. So this is probably the upper pouch here. So it's very high in the chest inlet. You can see it right now. Usually it's more to the left side than to the right. Okay, dziękuję. W porządku wszystko. So usually I grasp it through on the tip, because this part we will later cut off. So this is one of the most tricky and difficult part, just to separate it from the trachea. Sometimes it's very easy as the connection is not too tight, too strict. but sometimes it's really a challenge. O, to jest złapany. Krystian, momencik. Wiesz co, czekaj, muszę się obrócić narzędzie. Okej. Proszę, czuję to właśnie, bo położyłem go za nisko troszkę. Jest wszystko dobrze. So you have to go from one side to the other side, step by step. Be careful because here you can find from time to time the Hillos duct. So if suddenly during your dissection, the operative field is becoming wet, it means that you open the Hillos duct, so be careful. Stay close to the esophagus if it is possible. In this case, we don't need too much mobilization, but making the anastomosis very high in the neck would be a little bit difficult. So this is why I try to move it a little bit more. Still, we have a lot of tissue to dissect. Be careful here because it's easy to open the trachea. You can see how much right now we mobilize it already. You have mobilized it already, yeah. Still, there is connection to the trachea. A mogę mieć teraz to taki do trzymania, ten okienkowy? Okay, right now I will use for dissection the grasper that is, much wider and probably even safer. I think it's quite enough. We don't need to dissect it more. Pani doktor, proszę zamknąć tą sondę, bo za chwilę będzie uciekało tam powietrze. I always ask anesthesiologists to close the nasogastric tube, as in other way you will lose the space because of the gas escape. Okay, dobrze. Poprosimy nożyce teraz. So now we will open the upper pouch. Usually when you cut it, first you cut the muscularis. and then you cut the mucosa. Poprosimy teraz o naciśnięcie na tą sondę, ten doktor. Już momencik. Dobra, można nacisnąć teraz. Super, dobrze. OK, tak ją proszę przytrzymać. You can see the nasogastric tube is somewhere here. So this is what I said, that first you cut the... Proszę dissektor. Yes, you can see right now, this is the mucosa here. Troszkę cofnąć, proszę. Troszeczkę, super. So you can see that the blood supply is perfect to the upper pouch. So this is how I don't cut the tip because we will use it later for the traction. And then we cut the distal pouch. And as the distal pouch is very well developed, usually the part that is very close to the trachea is a little bit narrow. So I cut it just like here. Okay, it's already cut it, but what I will do right now, you will see at the moment that I will also cut a part of it, just around 2 or 3 millimeter, just to remove this narrow part, something like this. But please don't cut it completely. It will also serve you as a traction. Potrzebuję teraz grasper. Popchamy teraz sondę, pani doktor. Może być jakikolwiek. Proszę ją popchać. Okej, ja już ją mam, pani doktor. Jest w porządku. Dobrze, dobrze, jest wszystko w porządku. Okay, so right now we'll place it to the distal pouch. Okay, once again. Okay, still not. Just moment. Troszkę cofnąć ją, proszę. Troszeczkę cofnąć. Powoli, powoli cofamy. Jeszcze troszkę. Stop. Dobrze. Stop, 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 stop. Dobrze, proszę troszeczkę stop, 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 stop. Troszkę do tyłu. Powoli, powoli. Okay. Dobrze, jedziemy do żołądka. Okay, perfect.
Darius, what's the size of the NG tube, Valerio?
Oh, it's 8 French.
Thank you.
8 French. Okay, so right now we'll start with the anastomosis. Okay, potrzebuję 5-0. Dobrze, wyprostujemy sobie. So this is how we prepare the needle. You can see just with your finger, you straight up it just to accommodate into the trocar. It's just around 10 centimeters, sometimes even longer. And this is the way that I deliver it, like this. Okay, you can see, and right now I put it into the trocar and go down. Okay. Dissector, super. So we'll start with the first suture. As you can see, there is some blood in it, but not too much. Usually, what I do, I prefer to put, maybe this is also the case, because you can see that right now we'll have a direct anastomosis above the trachea and the fistula site closure. And this is my idea when I watch, okay, give me scissors. Proszę dać mi nożyczkę, tylko jeszcze może, no. Okay, just I show you my idea. Maybe this is a good example just to show you, because in majority of cases, we do the anastomosis having the azygos vein behind the esophagus. So in this way, you move the distal esophagus. Proszę mi dać Gasper. in this way, you move the distal esophagus. Benjamin, okay, so we already not. I will not do it right now because I already put the nasogastric tube down to the, yeah. But this is what we do, that we take the distal pouch above the azygos, like here. So we move it out of the space between the trachea and the anastomosis. But in this case, okay, we will not do it because I don't want to take the nasogastric tube out again. O, just a moment, okay. Poczekaj, szybko się wkręcił. Krystian? Nie, dobrze jest, teraz jest dobrze, okay. We had some technical problems, but right now it's okay. Let's look for the upper pouch. Once again, just a moment, okay. I can see it. So this is very helpful. As you can see right now, you can take it. Okay, pokaż mi igłę. Okay, the needle is somewhere here. Okay, pokaż mi to. So very important, just take all the layers, including the mucosa. You can see that the mucosa is somewhere here. I will take it once again, just take it a little bit more. Just going under the mucosa like this. Okay, so right now we have a full thickness. Okay, taking the needle out. And then we have to look for the distal pouch. That is somewhere here. Okay, we have to look for it. Okay, that's it. Okay, right now we have a full thickness of it here. Okay, so this suture is out. Usually if this is, it depends on the anatomy. Sometimes I start from the posterior wall, putting the first suture inside, but I think it doesn't matter because you will see in the moment that you can freely rotate the esophagus around. So it will be the first sliding knot. This is 5-0, something like a Vicro, absorbable suture. I always do it in the same way. So just repeating the same steps, don't change it. And then it is much easier to do it. You have to convert it. Okay, it's already converted. You can slide it with your instrument like this, but remember, don't close it too much because in other way you will destroy the suture. You can stop at this moment. You can take the upper pouch with this tip and just moving like this, you can bring the suture together. Lock the suture. And the third one for the safety. Okay, scissors, nożyczki. Okay, the sector. Okay, I will place another one and then I will cut off the tip of the upper pouch and also the part of the distal pouch. So as you can see, I am not looking for the needle, just I follow the line, the suture. Okay, I will correct the needle position of the needle a little bit like this. I think it's much better, not in this direction, but in this direction. That's a good exercise for every young surgeon, how to position the needle inside the needle holder. So you can use the previous one for the traction. But maybe it's better just to grasp it like here. Put it on the needle and take the full thickness. You can see it together with the mucosa. So as you can see, I have a good bite of tissue. So this is just step-by-step movement. If you take a long line enough, you can even use only one suture for the whole anastomosis, just checking, okay, it's out. Podejdź bliżej, Krystian, troszkę. Okay, so I glue the end here. It's not possible with monofilament, but with the braided suture, this trick is working. So the end of the suture is waiting for me, just you will see at the moment. You make a loop, and then you direct your instrument just to the end of the line. Then you close the suture. Before closing, you can convert it. It's not always that it converts itself. Sometimes you need to straight this line. If you do it in the same way, you always know at which direction you have to do it. So look, right now you can move even just keeping one instrument like this. You can close it step by step, just moving left and right with your instruments. Okay, and finally slide down and then lock it. Ja założę jeszcze, Krystian, jeden, potem będziesz szedł, dobrze? Dobra. A nożyce poproszę, może tu do prawej ręki. Okay, so right now we'll cut this thread. Okay, leaving one longer, and then I will look for this tip. Okay, it's here. Okay, I have to take it out. Okay, sorry. Okay, so this is the tip. So right now we'll cut it off. Okay, this is the upper pouch. Na podanie. Jeszcze jeden muszę znaleźć. Okay, we'll look for the other end. It's somewhere here. Okay, Christian is very helpful. Thank you. That's here. Okay, you can see it. So this is the distal pouch. So we'll cut it just, okay, like here. OK. To co, dysektor, poproszę imadło. Again, the needle position. Then you use the previous suture, the first one, to rotate the esophagus. Probably I will use this one that is longer a little bit. Okay. You can see that you can rotate the esophagus freely. You can go. You can take both pouches together. Come closer. I don't think that this is the distal pouch. I have to check it. Okay, now it's better. Yeah, you can see right now the whole wall of the esophagus. Maybe it's a little bit here, just a little bit of the muscularis. So we can take it a little bit more. Like this. Okay, it's better right now.
Darius, sorry.
Yes.
We are online, Professor Philippe. Then
Okay,
what
please
you
start with the presentation.
Yes,
We
we permit
record
to
it,
finish.
we will show you. Yeah,
Yeah.
we will show you later. Okay.
Yes, we
Perfect.
permit to finish to Alessio his presentation.
Okay, perfect.
Okay.
Thank you very much.
Thank you. Thank you. When you are ending, we want to reconnect.
I will let you know. Okay.
Okay. Thank you very much. Thank you.
Okay, perfect.
Alessio, se
Yeah.
vuoi.
Okay, I will keep on.
Yes, because it's only a question of time because Professor Philippe it's connected for an half hour approximately, and we must go ahead. Thank you.
Yeah, but I'm nearly finished. So, I mean, this is just to show you something that I showed you already before, which consists of the suture line when we do a running suture. And this is valid regardless of the fact that we are dealing with a duodenum or not. We try to lock it because in the past we were using third arm to pull on the thread, but if you just lose the tension, you end up by having a looser running suture, which increases the risk of leakage. On the other hand, when you do a lock-in suture, and we started using it from pyeloplasty, and we are using it for everything now, you achieve a nicely healed suture line, and you can see it now that we are doing this running, and this is just a bit faster, and then we go through the line to make it a lock-in, and therefore this stops the thread from prevents the thread from losing. And when you close it, is like having a sliding knot that closes nicely the line. And even if you have a third arm that allows you to pull on the suture line, if you do a normal running, the risk of having a loose suture line is quite high. So this should be the end of the posterior wall of the anastomosis. which consists in this case on the basically a linear suture line. In the case of a diamond shape, you end up by finishing the suture on the exact midline of the longitudinal incision, but this is basically a lateral duodenostomy. So this is the first closure, and then we go to the anterior part of the anastomosis to close it the same way with a running lock suture.
Alessio,
Yeah.
do you have experience with a Vlock braved suture?
No, I've not. I mean, I've used once when I was doing an adult with Hirschsprung's disease, and I have to say that you must know perfectly how it works, otherwise it's a mess because it ruins the tissues. But I believe that this is sort of adaptive V-lock suture, so this is the way we prevent it from losing. And in the adults, they sort of found this, but the issue is that you can do only on 3-0, and there is no V-lock on 5-0, 6-0. So when we do pyroplasty or infants or neonates, there's no way to use in the V-lock. But I agree, this is the same concept of using a V-lock to avoid the slippery of the linear suture of a running suture line. So this should be the end of the anterior suture, which basically consists of the whole anastomosis consists of two hemi running sutures, and this is something that we can do open. I'm not sure that you can do it safely laparoscopically if you are not really skilled, but you can do it safely with robotics, even if you are at the beginning of your learning curve, because this is very democratic, as we said many other times. In this particular case, we closed back the lining surrounding the duodenum sort for extraperitonealize the suture line in order to reduce the likelihood of the risk of contamination in case of leakages. But this is sort of, I'm not sure if useful or only cycle asthenic stitch from the surgeons that allows you to be safely in bed at nighttime, more than safe for the patient. So it's something more convenient for the surgeon. But at the end, you can see how the anatomy is back to normal and how likely is that all procedures reduce the risk of severe adhesions and even dysmotility related to adhesions. So even the bleeding and the fluids are very limited, and the patient had a nice recovery from this surgery that I believe is just finished. Show you just that we frequently break the thread more than cutting them, but this is sort of conventional aspect in robotics. So this patient has an unremarkable course. The interesting thing, apart from the, I would say, conventional postoperative course, is that even diarrhea settled. I'm not sure why diarrhea was related to this web, but he had diarrhea for months before, and after surgery, he had no more vomiting. His weight went back to normal, and his diarrhea settled. So somehow the duodenum is linked to the back passage, and I'm happy to answer if there are any questions. Thank you.
Thank you, Alessio. Great surgery, as always. Any questions from the audience? Comments? Well, we discussed a lot about this procedure today, actually. If there are no more comments, I think we can thank Dr. Piniprato again. And
Yes.
we've got a question from the audience to Professor Patkowski.
I have a question for Alessio Piniprato.
Okay, go ahead, Mirko.
Yeah, Alessio.
Yeah, as you can see, we are just doing the posterior wall, just having some technical problems. This is the suture for the on the posterior wall. You already turned the esophagus around. So this suture will go from inside but cannot, that's the problem with my needle, that I cannot move right now. Sorry. It looks that I am right now, but unfortunately I am inside the nasogastric tube. Okay, just a moment. Sorry. Pokaż mi, to jest koniec tej nitki. Poprzedniej, tak. So this is the suture that we placed before. So we rotated around the esophagus. So right now you can see that we have the posterior, we have turned around the esophagus. Okay, and this is the posterior wall. Pokaż mi tu od dołu. That is right now, okay? So the suture will be inside. Okay. You can see this is the other end, as the suture is a little bit short. So I will use the needle as an extensor. Yeah, thank you for your comments. I think that I can control it right now. So I will not fight with the azygos. As you can see, it's already closed from inside. So this is the posterior wall.
Darius, is Valerio speaking. If you agree,
you can start with Paul. Yeah.
Okay, thank you very much.
Good
Thanks
afternoon,
a lot.
Paul.
So, Mirko, if you want to introduce Professor Philip.
Thank you, Professor Philippe. It's a pleasure to see you again with us in the IFPLS group. And your presentation, the topic is very important for pediatric surgeon, because talk about a very complicated for many of us situation to treat laparoscopically. And Professor Philippe talk about the laparoscopy for malrotation. Thank you, Professor Philippe.
Good afternoon, everyone. Can you hear me well?
Yeah.
Okay. First of all, I'm very sorry for the disturbance in the schedule. That's what happened in our line of work, and I had to do. I say hello to Tarek. How are you? I just did an internal traction this morning. Unfortunately, no time to set it up as a live surgery, but it worked. It went very well. So I'm going to share my screen. Can you confirm that you have it?
Yes.
Okay. So I've seen on the schedule that Arnaud Bonnard was to discuss a similar topic this morning, and I'm sorry that I missed it. But I'm going to tell you about our experience with intestinal malrotation and midgut volvulus. So this is a pathology that occurs very close to the duodenum. So that's probably why I believe it fits in today's main topic. Okay, now one button is not working, this one is. So we are all pediatric surgeons, so I'm not going to remind you in length about what malrotation is. It's abnormal fixation of the midgut that leads to a risk of midgut volvulus. Midgut volvulus is a catastrophic event that we want to prevent or to treat as one of the most urgent surgery in our field. So these are the anatomical drawing on how the bowel goes back into the abdominal cavity after its stage of elongation in the umbilical stalk. And these are on the left side, the normal anatomy that we all learn in school, and the anatomy in case of malrotation where the duodenum does not cross the midline in the retroperitoneum, with a duodenojejunal junction staying on the right, and a cecum that is not fixed in the right lower quadrant, but rather in the middle of the abdomen, with peritoneal attachments in front of the duodenum called Latz band. Though they rarely occlude the duodenum, occasionally they can be tight enough to impair the function of the duodenum. But mostly, this creates a very narrow fixation between the small and the large bowel, which is prone to twist on itself, as we call the volvulus. So the volvulus are most of the time very early in life, 90% below 1 year of age, but there are a few case reports of occurrence in adults. I was called once with my adult colleagues here at the hospital because they found a volvulus and they didn't know what to do with it. So it does occur anytime in life. Two situations. One, the acute volvulus, which is a very acute emergency. And two, the post-symptomatic cases or the asymptomatic ones discovered on imaging, on essentially on ultrasonography. When there is a midgut volvulus, we know the symptoms. We know that if we are not quick enough, death or chronic intestinal failure will result. The diagnosis, plain X-ray, is very non-specific. Nowadays, the first test is ultrasonography, which will look for the superior mesenteric artery, the superior mesenteric vein, as they cross behind the pancreas. And normally, the vein should be on the right side of the artery. When it is not, one must suspect an anomaly of rotation. Occasionally, the ultrasound will be sufficient to diagnose the volvulus, as you can see here with this color slide, a very distended stomach, because of this leads to occlusion of the duodenum, and the twist of the vascularization of the mesentery. The second diagnostic test could be an upper GI, as you can see here. And now, the conventional treatment is, of course, open surgery. And you can see here the laparotomy, which is usually a transverse upper abdominal. And you can see here, head is here, feet are here. And you can see here the volvulus at the base of the mesentery. Now, it has been shown that you can see exactly the same picture by laparoscopy. And I will try to show you what are the tips and tricks for this type of procedures. So in 1936, Sir Ladd described his procedure, which first and for all is a procedure to reduce the midgut volvulus, as you can see here. But we also use it for malrotation, in which by dividing Latz band and widening the base of the mesentery, we are going to put the patient in a non-rotation situation with the cecum in the left lower quadrant and the jejunum completely on the right side. And this wide base of the mesentery should prevent any recurrence of the volvulus. So for laparoscopy, this is the position that is recommended. So the target being here, the surgeon will be at the feet or near the left knee in bigger children in order to have a direct vision to the screen regarding the target, which is basically working on the duodenum. I'm sorry, I don't know what this frame is for. We usually use a 5mm telescope except in infants where we love to use the 3 mm one. And we use 2 or 3 instrument ports. I never hesitate to add 1 port whenever I'm in need. But nowadays, I use a lot of transparietal suspension to retract the liver, but also if I have to retract an intra-abdominal structure, for instance, if I need to lift the duodenum, instead of putting one more hand, I put the transparietal traction. Now, let's start with the uncomplicated malrotation, the one that has been diagnosed on an ultrasound. The first step is to confirm the diagnosis. Especially in young infants, we know that the cecum can be quite mobile in the abdomen. So it is the cecum that we need to identify first. Then we need to check if the ascending column is properly fixed in the right flank with a normal tight taut fascia. And then we need to find where Tight's angle is. I'm sorry, I will show you a few videos, but I don't have a good one showing how to find it. You have 2 options. One, you identify a very easy place in the anatomy, which is the ileocecal junction, and you run the bowel upward until you reach Tight's angle. More easily, if you lift the transverse column up in its middle portion, you will identify in the mesentery, the superior mesenteric vascular axis, the colica media artery, go down on it until its base, its junction with the superior mesenteric artery. Tight's angle is right to the left of this when there is no anomaly. If you don't have the small bowel fixed to the left of the superior mesenteric vascular axis, then you do have a malrotation and you need to do something about it. Now, a LATS procedure for uncomplicated malrotation first calls for the release of all LATS band and then to enlarge the base of the mesentery and until you can run the jejunum in the right flank, and the ileocecal junction goes easily in the left lower quadrant. In this procedure, no suture. In the past, appendectomy was performed much more often than we do now. Nowadays, I tend not to do an appendectomy during an uncomplicated malrotation procedure. This is what it looks like. So once you enter, what you see first is the small bowel. Most of the time you would see the transverse colon and the omentum. Here, just under the liver, we identify what at first looks like the transverse colon, but if we run it to the right, we don't find anything. If we run it to the midline, there is the ileocecal junction. The next step is to identify the duodenum, and these are the famous LATS band that run between the cecum that is here in front of the duodenum that you will see in one moment right here under this band. And you see that in these uncomplicated cases, the bands are quite tight and quite generous. So in infants, you can divide them without any form of cautery. In bigger kids, well, you know, blood and good vision in laparoscopy are not very good friends. So I like to use some form of energy and with a 3 mm instrument, monopolar is the easiest, or the Roby from Storz bipolar instruments that include dissecting forceps, grasping forceps, and scissors. So you need to actually be on the serosa of the duodenum that we are starting to see now, and to mobilize that duodenum somewhat like a Cocker maneuver. Here is the duodenum, and once you have identified the duodenum, you can see that you can actually run the bowel completely from the root of the mesentery to the right. Now, once you think you are done, double check there is almost always a few more adhesions that you can release, a few more bands that you can release. Now, here is the preparation of the base of the mesentery. You can guess where the pancreas is under the peritoneal layers. And for me, see now you can see nicely the pancreas, and under it you see the mesenteric vein. That's your landmark to ensure an optimal mobilization and widening of the base of the mesentery. Now, so this is an operation that is not too challenging technically if you compare it to the suturing that we have seen with Professor Patkowski on the esophagus, but it's, well, boring, and you never know when you will, if you are complete or not. Here, this is the ileocecal junction, and you see that it goes easily down in the left lower quadrant, and that the mesentery is quite wide now. Now, what about when there is a volvulus? Challenges before the procedure. One, most of them are small and little. So you need to be experienced in neonatal laparoscopy. Two, look at the child. If it is really bad, if there are obvious signs of necrosis, of shock, maybe don't start with laparoscopy. You can open the abdomen and untwist it in 3 minutes by open surgery. Now, if it is an emergency during the night, is your setup right? Do you have the equipment that you require? Is the anesthetist comfortable with it? Are the nurses ready to do this type of procedure? And the last one, and this is true for every laparoscopy, don't do something if you are not ready and prepared to convert and to do the procedure with the conventional techniques. Now, during the procedure, you are in a small space. If you are lucky, the bowel will be flat, but if you are a little bit at a more advanced stage of the volvulus, the bowel will be distended and obscure your vision. That's the case, do not hesitate to convert. Now, the bowel of infants is very fragile. You will need to handle it with some force, enough but not too much. And the big question at the beginning was, how do you untwist the volvulus with chopstick? So conventional surgery, you first undo the volvulus. That will not work in laparoscopy. In laparoscopy, what you will do, I'll show you the video, is first go for lats band. Once the lat bands are divided, then the volvulus, the base of the volvulus will be free, and you will be able to untwist it most of the time. So this is a 4-day-old infant. As I say, to give light to the duodenum, we like to put a traction suture, and this is the twist, the volvulus at the base of the mesentery. Now, this is a futile attempt to untwist it, and we go first to the duodenum. As I said earlier, the goal is to reach the serosa of the duodenum, and everything that is in front of the serosa, all those peritoneal folds, are lats band. And you really need to follow that duodenum, find all the bands. You see here we are reaching the base of the volvulus, and by pulling on the duodenum, you expect the volvulus to come undone. Well, it will come undone only if all the bands are divided. Occasionally, by putting on the duodenum, you will see it. Now you can really see here the volvulus on the left of the screen. One more band. And now you are going to run the small bowel all the way around until you reach the cecum. You have seen the appendix popping around, and you know now that the volvulus is undone. Now, for safety, I usually run the bowel backward a couple of times until I go for the base of the mesentery. See on the right of the screen, that's the ascending colon. And now we have the duodenum in our left hand. The ascending colon is in the bottom of the screen, and we are dividing all the attachments in front of the mesenteric train that you clearly see in the middle of the screen. And this is widening of the mesentery. Occasionally, when undoing the volvulus, as you can see here, is difficult. One maneuver that I tried once after releasing as much pens as I could and not being able to undo the volvulus. You see here, we are pulling, but it doesn't come. You see that there are probably 2 or 3 turns around it. That's the distal ileum coming out of the mesentery of the volvulus. We added 1 trocar in the right lower quadrant, and then the maneuver consists in en masse push everything above the instrument that comes from the right iliac fossa to the base of the volvulus, and you push everything around. You see that there are a lot of lymphatic enlargement in this case, and you push everything above the forceps, which is the axis of your orbiting maneuver, and you've seen that we reach the cecum. That's the sign that the volvulus is undone. Now, further bends, and now we can actually pull the jejunum to the right, as we have done in the previous case. There's not an extensive literature about malrotation and volvulus, starting from 1995 and the team of Utrecht, David van der Zee and Klaas Baats, the team of Memphis. I pay respect to the one who was my chief in 1989 and introduced me to laparoscopy, Tom Loeb. And then a lot of discussion to know what is the indication. In 2017, with the colleagues from Strasbourg, Lausanne, and Montpellier, we participated in a retrospective study on the early experience with it, comparing a group of kids who had laparoscopy. These are babies with volvulus, and a group that was operated by open surgery. We found that in the two groups, the patient characteristics were quite similar. The procedure was not always successful. Remember that this was the beginning of the surgery, and 25% were converted, mostly because the surgeon didn't feel comfortable that he had completed all the mobilization of the mesentery. The operative time was quite similar in the two groups. The hospital stay, which was much shorter in the laparoscopy group. The time to full diet was much shorter in the laparoscopy group. Now, several kids in both groups underwent redo surgery. What is important is to know that in the laparoscopy group, in 4 kids, only mild adhesions were found, and 2 of the 6 had negative exploration. That means surgeon that was not confident in this early experience that he would actually get appropriate results. In Luxembourg, our experience since that publication has been increased. We had only one case where we did a primary laparotomy, child had a complete necrosis. It was an open and closed situation. 2 of those new cases were converted. That means that of the 17, 15 were successfully completed. The 2 cases that were converted were surgeons having to do the operation alone with a less prior experience. We had 1 recurrence, and this child was initially operated by laparoscopy in our center after an open surgery elsewhere. And he recurred after the operation for recurrence. We redid it by laparoscopy, and now he seems to be fine. 1 child developed an adhesive band obstruction 4 months after his laparoscopy. So that's our experience, which is quite positive. Now, what do we find in the literature? Comparison of open and laparoscopic LATs in a group of patients. You see 86 open, 53 laparoscopic, but elective cases, no cases of volvulus in 2016. And the main difference they found was the length of stay was much shorter for the laparoscopy group. After this type of publication, a committee of the American Pediatric Surgical Association published their expert opinion on the use of laparoscopy for malrotation, and they concluded that this is a very helpful approach to distinguish true malrotation with a narrow base, which is prone to volvulus, to other form of abnormal fixation. But they found, and this was in 2015, no evidence or minimal evidence to support the use of laparoscopy when there is a volvulus that is diagnosed before operation. An Italian group in 2016 did a meta-analysis for this topic. What they studied were 259 patients from 9 studies opened by laparoscopy versus 750 open. There were few volvulus because it was considered as a contraindication by most authors. The conversion rate is quite high, but it does improve with the learning curve. They confirm that the time to full feed and the hospital stay are shorter in laparoscopy. They have an overall complication rate that is smaller in laparoscopy, but twice as many recurrent volvulus after laparoscopy. No adhesive bowel obstruction after laparoscopy versus more than 10% after open surgery. And I think this adhesive bowel obstruction is probably the biggest advantage of laparoscopy. More studies in the same, they found same findings. Now, why would there more recurrences after a LATS procedure done by laparoscopy than a procedure done with open surgery? Well, this is the type of study that I think is not helpful. They did a survey among surgeons attending a Canadian Association of Pediatric Surgeons meeting. And for those surgeons, the main reason for recurrence were no postoperative adhesion because of the laparoscopy. Second cause, incomplete procedure. But there is a fear that because we have big advantages, laparoscopy not promoting adhesions, we lack the fixation that the open surgery offers. The team from Utrecht reviewed his experience with 37 cases. That becomes quite a nice series. And they had 7 recurrent symptoms or recurrent volvulus. And in all of them, what they found was an incomplete procedure, an incomplete release of the lat span. So in conclusion, I would like to say that laparoscopy is possible in many cases of malrotation and in cases of volvulus. It is not an easy procedure because you lack of space and you lack the tactile feeling that you can have in open surgery. It does improve the outcome of the patient, but at the cost of maybe a little bit higher recurrence rate that probably is most of the time linked to an incomplete procedure rather than the use of laparoscopy itself. And with this, I would like to thank you for your attention.
Thank you very much, Professor Philippe. Any question from the audience? Because we switch to the operative room of Wrocław, and we see the end of the intervention for esophageal atresia performed by Professor Patkowski.
Okay, we are almost done. As you can see, this is our anastomosis, but this is the suggestion. This was completed by Christian, my assistant. So we are already done with the anastomosis. The only suggestion that, I always avoid to complicate the surgery, but my assistant told me that I have to do it. It means that just to put the pleura on the fistula side closure. And as we have a lot of pleura, so maybe we'll try to put it in this way that we incise it. You can see the flap. So we'll put a flap of the pleura on the fistula, just to have a kind of, separation from the anastomosis. I don't know whether it works, but as they asked me to do it. So instead of doing any tracheopexy, so we'll do a pleuropexy, okay? It's always that you have to move very slowly and adjust your instruments to have a good alignment. Well, unfortunately, that's it, what I lost. I lost my needle. I will have to take it once again. It's here. You can see it, okay? Okay, right now I grasp it. Okay, so as you can see, we'll put a pleura on it. I will check whether it works or not. Okay, it seems that it should work on this side, okay. Also, of course, it's also with a sliding knot, so you can see the advantage of the sliding knot, that you can use it almost in each situation. I don't know whether it works, but this is another one layer of separation of the fistula from the anastomosis side. So as you can see, we are finished with the procedure. We are not going to do anything more. As the procedure was uneventful, we are happy with the anastomosis. So I will not put any drain into the chest. The only drain that I was asked by our anesthesiologist, it's for local anesthesia. So we will see at the moment how we put it. For the continuous infusion of the local anesthetic. Okay, that's for you. So the needle is out. Okay, so right now we'll put the catheter. Pokażcie mi ten cewnik. Ten mniejszy. No jaki tam macie? Co macie? Który dla was jest? Proszę mnie nie pytajcie. Dajcie 20.
Darius,
Yes?
hi. Very, very nice. The anastomosis is so nice. Will you leave the NG tube or will you remove it?
Yes, that's our experience that we always live inside the NG tube. So tomorrow we'll start with nasogastric feeding through the tube. And on fifth day, if the baby is doing fine, if there is no infection, if there is no saliva from the throat, we'll start with oral liquids. If the baby is swallowing, we will take the nasogastric tube out. So we will not do a contrast study if there is nothing with the baby. We stopped to do it. We started to do it since almost 1 year. Okay, so right now we'll try to go under the pleura. Just we're rotating the scope. I will go under the skin, and at the moment you should see my needle somewhere here. It's here, okay. Just look for this. So just going under the pleura, rotating. The needle is a little bit curved. So this is how you can see I am going just near almost we are almost at the vertebra level. So give me the syringe with the air. So we'll inflate it with the air. Just to have a little bit more separation of the, that's perfect, okay, even too much, okay. Okay, give me the catheter. So this is the epidural catheter that I place inside. Tak. Ja zaraz założę, tak? Zaraz pani założę. Okay, so the catheter is in, you can see. So I remove the needle out slowly.
And Darius, did you
Yes.
ever to do the cryoanalgesia?
Excuse me?
Did you ever try the cryoanalgesia, the frozen of the...
Yes, we are using it, but we are using it for funnel chest deformation. Tak. We are using it, but not for this baby. Okay. I think the sonde.
I think we lost the connection with Rocklove, or it's just me?
No, me as well.
I mean, Mirko, if you agree, we can have a...
Beginning at the starting.
Okay.
Can you hear me?
Now we can hear you, Darius, yes.
Yes, you can hear me. Just a moment, okay, Piotr.
We lost him again, I think. What do you think, Mirko? Half an hour of break. We see each other 15 past 2. Switch on your microphone, Mirko. Sorry.
Yes, I think it's a good idea. So we can
Okay.
relax, so eat something, drink something, and come
Okay.
back.
I'll see all of you at 2:15.
Okay.
Yes. Can you hear me right now?
Yes,
Yeah,
yes,
right now,
Darius.
yes.
Now we can.
Sorry, we had some technical problems. So just to summarize, at the beginning, the insufflation pressure was around, you can see that right now I put some local agent just to have a local analgesia. It works perfectly. So we are happy, okay. Yeah, that's it. So at the beginning, the working pressure was 6, and then we switched to 4. And for the whole procedure, it was just only 4 millimeter of mercury. The baby was very stable. The oxygen concentration is just around 50% and 96 saturation. Heart rate is 140. The baby is stable, nothing special, yeah? Our anesthesiologist is very happy with our surgeons. Okay, so that's the end. As you can see, there was no coagulation, no suction, no irrigation. The tissue are very viable, so we are very happy, and that's the end of the procedure. So thank you very much. I will come. If you have any question, just I will be happy to answer it.
Yes, Derek, one question from the ocean, Dr. Kotari. You have multiple trocar position at different rib level. How is the single epidural catheter going to help control
You can see. You can just
additional
I
levels?
show you. You can see
Yeah.
just in the middle. Okay, there is. We will also put the local anesthesia for the trocar placement. So this is just how it works. That's okay, Marco. Mirko,
Okay.
sorry.
Okay. Perfect. Perfect. Thank you. We think that we take a break now.
Okay.
Okay.
So,
We
at
come
what
back
time?
at a cart past 2.
At 2:30.
Yeah.
Okay. Okay, I
Okay.
will come.
See
Okay.
you later.
See you. Thank
See
you very
you.
much for watching.
Bye-bye.
Thank you.
Thank
See
you very
you.
much, Derek.
Thank
Thank you.
you.
Valerio, grazie. Thank you very much.
Thank
And
you. I'll see you later.
to all the audience, see you later. Bye.
Okay, perfect. Okay. So I am on time.
Thank you, Derek.
Thank you. I thought that it was 30 minutes more. 15 minutes more. Okay. That's everything is okay.
But there is no online people now. If you want to waste something, it's no problem.
That's 85 participants I can see, 85. I don't know whether there
85
are
now. Before,
85 computers connected. Yeah.
yes, before we had 116.
Perfect.
Yeah,
Really
yeah.
perfect. Really perfect. Thank you very much.
Valeria is online.
Yes, I'm ready.
Valerio,
Darius,
thank you very much.
in the
This
meantime,
question and answer and also the review of the literature is really perfect. Congratulations for you.
thanks, Darius. I've got a question. I don't know if you are tired or you want to talk
I
again.
am okay. I am okay.
What about leaving a smaller NG tube, like a 4, just to feed the baby?
Yeah. So the problem with 4 is that you cannot place it because it's so soft, it's not going, it's curling, you cannot go down. I asked it for 6. Unfortunately, they didn't have it.
Okay. And
And
the other option.
The other problem is, of course, they had the 6 one, but there was no opening at the end. I always ask about the nasogastric tube that has the hole at the end, in case that you have any problems with the anastomosis, anything like that, you can exchange it over the guide wire, So this is my idea that if you are using, but for many, many years, I didn't had any such a problem, but in case, so this is just old-fashioned way to manage, just to have a nasogastric tube that has the opening at the end,
Sure. Sure.
That's only.
And what about not leaving any NG tube?
I know that there is the study from USA that one of the main source of stenosis is the nasogastric tube. But if you look at this study, it comes from many, many centers that
The
are,
Midwest Consortium.
they're
Yes, yes, I
operating,
remember. I remember.
just single cases, and it's really difficult to draw any conclusion from such a study. So I don't agree that nasogastric tube is a source of stenosis. We have around 30% of stenosis, 30%. And that's my feeling that probably the source of the stenosis that all the cases of type C we complete with the anastomosis, even that there is very severe tension. But on the other hand, sometimes you perform a really perfect anastomosis without any dissection. You are so happy with the anastomosis, and then 2 months later you find the baby with the stenotic esophagus. So it's not the case. I don't know. We are looking for the factors that influence it. Right now, my assistants, they are checking all the video recordings, looking for the technique, estimating in blind way the quality of the anastomosis, and we will try to draw any conclusion. What was the reason, whether there was too much sutures or not a very good quality anastomosis, too much tension. That's a lot of factors to discuss.
Yes.
Maybe it comes from the suture because I don't have the perfect suture. I don't have the vicryl. So maybe this is, many years ago, we have a lot of discussion about the quality of the suture. Right now, we have other problems, we stop to discuss about the quality of suture, but maybe this is the source for the stenosis. I don't know.
I wanna tell you my experience, Derek. I performed three thoracoscopic repair of esophageal atresia, three type C. And the last we performed open because the baby have cardiac problem and very, very little. But there is a very incredible difference for the vision. With the thoracoscopy, you have the vision. And when I back to the open surgery, I had difficulties because it's very thin, the esophagus in the hole in a very little thoracotomy. And for this reason, I said to my anesthesiologist, no, no more, no more, only thoracoscopic repair. It's it's
It's
easier.
Yeah, it's
Easy.
a perfect procedure. Since the beginning that we started in 2005, all the cases, primary cases, are done only by thoracoscopic approach. We didn't perform any open surgery for primary case, and still we are happy to have no conversion.
Yeah.
Can you imagine that this year we had probably 6, 7 at our department, and I did surgery for more than 10 cases in other departments. So tomorrow I will go to Amsterdam, we'll finish. Recently I did a case in Oslo. Of course, in Florence we did, in Bratislava where I was in Ukraine. So that's a lot of cases that I did, and all the cases are always in the same way. So just repeating the same steps. And right now for us, for our department, it's really like a standard procedure. Of course, everyone would like to do it, but still, we have just only 2 guys that are doing it, as they are always present at the operating room.
Yeah.
Some part of today, half of this anastomosis was done by Christian, who is my assistant. He's really perfect. All of them are really perfect in endoscopic sutures. They are very well experienced. And right now, I can travel and they can do it without any problem.
Perfect.
Mhm.
Yes.
Let me know what we have on the schedule because I don't know whether we
Yeah.
have five
We
surgeries.
schedule. There is the IPLSOG News Corner
Okay.
by me, but it's very short. I show only that we have more than 500 follower, and the connection has almost 500, exactly 488. So the connection and the follower grow day by day. I receive many requests of connection every
Perfect.
day. So yeah, yeah.
Perfect. Every place I visit, wherever I have any lecture, the last slide is always about pediatric life surgery groups, showing people that they connect. They can visit us on YouTube. There is a lot of followers on the YouTube, you know.
Yeah, yes, but there are also some question, but it's possible the ACM platform it's only valid for Italia participants. This is a question by Luan Alvarez Martinez. I don't know if in the organization we can obtain the certificate of attendance or credit European or worldwide credit for the other surgeon, but I don't know this one because
But
I think there is a problem for the
yeah,
request of European credits or not.
yeah, and you know, sometimes people connect and they
Solo quello il problema.
it's not easy, you know, it's not easy to check whether they are connected or just only the computer is connected, you know. So
Yeah.
it would be difficult, you know.
And for the question regarding the thoracic surgery meeting held in February, I have sent several emails without being able to resolve this situation. So I am taking this opportunity to ask this directly on this forum. I think to have the access to all the meeting, it's possible to become associate and of the IPLSOC, then you can have the free access to all the meetings. So if you want to to see the meeting, the past meeting, you can do it in this manner. And Alfonso, good morning.
Morning, Alfonso.
How are you?
Switch on your microphone.
Yes, I was already connected. I don't know if Luana is he just asked for to be a membership.
I don't know.
We asked her if she applied for to be a membership of the group. So what I have seen, and I just I want to share one slide. Is I don't know if you can see my slide. This is this one.
Yet.
Just
Not yet.
just a moment.
Okay.
So this is also the threshold. I think that this is the situation. We have more than 108, 110, also 120 during the morning, I have seen, but many people don't ask to be member of the group. So I just renew to all the participants to apply to the group and to ask for to be a member of the group. I just want to remember to all the participants that all is it's just to because the group has to grow again to have more membership, and the support is essential also for funding the organization of surgery session. And you know they also just apply for the website. It costs some money, and I think that 50 euros is just a very little. It's something it's very little, and this is incredible value. Like you have seen all in the morning, you have seen the procedure from Dario directly. You have seen the expert discussing about duodenal atresia and how to do it, also in people, and also how to do surgery. So I think that this is really a very good, I think that the finality of the group is very important to renew this, to invite. So I think that, Darius, I don't know if you are agreeing with me, but I think yes, that that we have to do the corner, the next corner has to be in the middle of the morning. What do you think about?
Yes, it's a good idea. It's a good idea just to, and maybe
When all the people is connected, almost is connected. So we just send again the message to all the people to ask for to be a member of this group. This group has the necessity to grow again, and also because funding is necessary also for the web association, and also the connection, all the stuff is small stuff, but I think that's essential. So that's it. This was my corner, treasurer corner. It's always to
okay.
all
Just at the beginning of every hour meeting.
and of course, the question of Luana, I think, is important because the credit are valid just for Italy, but we have to see if how to do international credit. And so I think this is an opportunity to grow. And maybe we have the chance to be. Giovanna has a question.
Just Alfonso, just
I am also
okay, Giovanna. Yes.
disturbing a little bit. So I want to go back to the credit. So I discussed this problem with Paolo De Coppi, who is now our EUPSA past president, but we will be very happy to collaborate with you in order to assure European credit and international credit. You know, EUPSA can do this very easily. And I received just now a proposal also from Paolo, who is connected today. So why not to do? We will be very proud to collaborate with you. We are collaborating with other associations, mainly with APSA, with Global Surgery, but our group, it's a very strong group and followed by a lot of people, and we will be very, very happy to do this. So I invite our president and executive board to think this. This can assure credit. So it can give some advantage without changing nothing in the organization of the group.
Mirko?
I think that there is is necessary to present very well the advantages to be membership, not only showing in the chat, but if Alfonso can and wants to show all the video that you can choose during the meeting in 10 minutes. So all the advantages that B membership can do. So I think that can be important for have more adhesions.
Paolo, you are connected. Would you like to speak? Hello, good to see you. Your microphone is switched off. Oh, that's okay.
Hello. Hi, Derek. Hi, everyone. Thank you, Giovanna. I'm sorry I didn't follow all the meeting, but I really enjoy some of the talk and the surgery that was done. Yeah, I endorse what Giovanna has presented. I think what you do is great, and I think certainly EUPSA could help with the accreditation and also spreading to more internationally, and I think would benefit, of course, given still all the freedom that the group has established, and but I think ultimately it would be good to everyone to listen and to participate to this meeting. So we will be delighted to help.
Okay, thank you. Mario?
I agree what say Giovanna. I think that the problem of international accreditation is the cost, because Alfonso know very well that we have about 4,000 euro in our account, and don't all the participant pay the fee, the annual fee. This is the problem. The problem is what is the cost of the international accreditation? Because the Italian accreditation, I use my fund of university fund, and don't touch the money of the group. I think that the big problem is the cost of this operation. This is my opinion.
That's the reason why, Mario, sorry, that today we have more than 100 people connected with directly with our with the web line. And so, I saw just to the participant, and almost 50% of the people just requested to be member of the group. But we have more than 50% just following us, but is not they not requested to be a member of the group. So I think this is the gap. You are right that we need more more money to be also to have international credits. But I don't know how much is international credit.
But if you want, Paolo and I, we can explore this aspect, because we used to offer international European credits, and then we can try to find a solution. Paolo, what do you think?
Yeah, absolutely, Giovanna. I mean, I clearly think this initiative that needs more visibility and more people to listen. And with the credit, I think it would certainly bring more people, and we can find a way with UPSA also to absorb some of these costing.
Yeah. And the question is, how many people do really need this international certification? That's the problem, because, for instance, in Poland, it's not so important. Of course, you can show it to the authority of the university that you are connected to the international society, that you are active. But on the other hand, it doesn't give any special value in Poland to have the international, accreditation. So that's my question only. I don't know how it is in other countries,
Derek, another problem underlined by Luan Alvarez Martinez. Thank you for your responses. Credits will be fantastic, but in addition to that, for example, at our hospital, they require a certificate of attendance this meeting to justify the absence.
Oh, that's okay. But that's a good thing, because if they need the certification, they should be a member of our society. So we can issue the certification, but first you must be a member. That's the simple solution. And maybe we should ask Alfonso, or maybe we can prepare together with Mario, just from technical point, that we should send the email just remembering that you have to pay and become a member, just to, for instance, just to obtain a certification that you spend the whole day looking at our meeting, But it's only for members, not for everyone. Of course, this is also the advantage of our society, that you can connect for free and watch really brilliant people showing everything from different points of view, you know, and discussing one subject in one day in every aspect. That's really the advantage. But of course, in today it's really difficult to do anything without any cost, you know. So that's a lot of costs. Most of them Mario is taking. But of course, we need more money. So maybe this is the way to get more memberships, just only for giving them certificate for attendance. Yeah, Alfonso?
Yes, absolutely. I think that you are perfectly right, Darius. And also they can find exactly the mail of the group that this is online. They can just email they asked for participation to be a membership of the group, and that will be satisfied everything, every aspect. I can do that, of course.
Yeah. So we can prepare an official paper of certification with a digital, you know, signing, you know, we can do it and we can send to everyone who is in it. Yeah.
Perfect. It's okay.
Giovanni?
Very shortly, international and European, particularly European credit are very important in many European countries. So, and also give, give more importance to our meetings. So I think it is good to do both things. First, as you say, Darius, to ask for membership, to give a certification, and then to try to have an international accreditation. Both things may be very qualifying for the group.
Oh, that's the comment from audience that the idea is great. So maybe people can.
There is the comment in the chat.
Yeah. Mm-hmm. Thank you very much for your comments. Okay. Okay, so what's the next subject right now?
Darius, if you want, we can conclude the video surgery session. So I'm gonna give the floor to my assistant. She's sitting just right. Me, Dottoressa Moggiati Mirella, she's gonna present us a case of robotic treatment of duodenal duplication. Okay, I'm gonna switch off the.
Okay. Can you hear me? Okay.
Yes.
Okay. Good afternoon. Sorry. Okay. Good afternoon. I would like to thank our president for this opportunity. Today, I will present the case of a 17-year-old with cystic duodenal duplication. The boy, who was suffering from acne and was overweight, underwent an endocrinological consultation and made an abdominal ultrasound. Due to the incidental finding of a splenic cyst and duodenal duplication, he underwent a pediatric surgical consultation. MRI, cholangiography, abdominal CT scan, and upper GI endoscopy were performed. In December 2021 and April 2022, interventional procedures were performed to sclerose the known splenic cyst with alcohol, resulting in a resolution of splenic cyst. Later, due to the onset of episodes of epigastric pain, further diagnostic investigation were carried out, which revealed an increase in size of the duodenal duplication. Therefore, after a careful review of the literature, the decision was made to proceed with robotic enucleation of the cyst. I will therefore focus on the intraoperative management of the patients without going into further details about the preoperative diagnostic investigation. In this procedure, we used the Da Vinci Xi surgical robot and specific instruments divided between the robotic table, the open table, and endoscopic equipment. This slide shows the people who were involved in the operating room. The primary surgeon is at the robotic console. Then there are two assistant surgeons, one of them with endoscopic skills who performed the endoscopic procedure. Since as a team we were at the beginning of our robotic learning curve, we had a fourth surgeon, Dr. Pini Prato, as a proctor, who helped us to accomplish the final results. The patient was placed in a supine position with arms along the sides and the surgical table. An L-shaped anesthesia screen was used during the endoscopic procedure. And finally, an additional monitor was extremely useful to allow the assistants to follow the surgical procedure. Trocar positions were marked and all trocars were aligned as shown in this picture. Access to the abdominal cavity was made through the first trocar at the umbilical level. CO2 insufflation began at 14. 3 additional trocar, 8 mm robotic trocars, and 1.5 accessory trocar were placed. We used the accessory trocar to insert the accessory instrument and aspirator. Target anatomy and docking were then performed with proper alignment. And after inspecting the abdominal cavity, the omentum was opened to fully mobilize the duodenum. The anterior and lateral portion of the duodenum were examined and no duplication was identified, as you can see. For this reason, an intra-abdominal ultrasound was also performed, confirming the intraluminal lesion. Then, an upper endoscopy was performed, which confirmed the presence of the intraluminal formation that was distal to the major duodenal papilla. Using robotic instruments, we double-checked the position of the duplication. Here you can see the robotic intra-abdominal light and instruments during the endoscopy. A monopolar scissor was placed on the right hand and the prograsp on the left. The anterior wall of the second portion of the duodenum was incised with the monopolar scissor. The duodenum was opened, and after coagulating the mucosa and aspirating the blood, the duplication was externalized. A circular incision of the duplication mucosa was made, followed by blunt enucleation, leaving the posterior wall of the duodenum intact. Meticulosis hemostasis was achieved using monopolar scissor and bipolar Maryland forceps. A careful washout and meticulosis hemostasis performed identifying the edge and of the posterior wall, which were sutured continuously, sparing the papilla. And the final step was the closure of the anterior duodenal wall with a full thickness running suture, as you can see in this video. We don't use outer block suture, but braided suture. To check the biliary tree, intraoperative anterograde cholangiography was performed. Under laparoscopic vision, a purpose string suture was placed at the gallbladder. A percutaneous needle was inserted into the gallbladder within the suture. And after contrast injection, fluoroscopy showed normal biliary tree canalization. Then the needle was removed and the gallbladder suture was tied. Unfortunately, we couldn't retrieve the picture intraoperative cholangiography. At the end of the procedure, abdominal cavity was irrigated, a drainage was placed, and duplication cyst was removed using an endobag. Then the pathology confirmed the intramural duodenal duplication, and now, after one year, currently the patient is in a good general condition and he had no further episodes of epigastric pain or vomiting. Thank you for your attention.
Thank you, Mirella. First of all, let me thank Alessio Piniprato for his help. He's been invaluable. And as a first comment, I will say that our main problem was to find the cyst. We couldn't see the cyst from outside the duodenum. Well, we knew that the cyst was there, but we just couldn't find it. So we struggled a bit or a lot. First with ultrasound, then with the endoscopic procedure, and the cyst was quite mobile as well. So it was there and there and there. And eventually we've been brave, Alessio, been brave, and we opened the bowel and we found the cyst there. Any comment?
So this was my question. How did you find it? Because it's not easy, you know. So this is from my experience. If you have, for instance, a duodenal web, it's difficult to find, even that the duodenum is dilated, but usually it's not dilated until the level of the web. Usually the web is a little bit far away. So even with this application, it was really a challenging case. So even that you get it, just to excise it properly, it was really tricky. So congratulations.
I don't know if Alessio is still connected. Are you there, Alessio?
Yes, I am.
Would you like to make any comment? I mean, you've been the man.
No, I agree that to find it, this is why I showed before that we resorted on a duodenostomy, because to find the web or to find a duodenal lesion on the medial aspect of the duodenum is not easy. We basically checked all the pancreas and everywhere, but we could not find it. So at the end, we knew that it was there, and we did endoscopy that confirmed the presence of the lesion, and so we had to open the duodenum. But until we opened the duodenum, we could not be sure that we found it. So it was a bit scary. I don't like scary things during surgery, but this one was.
Okay, thank you again. Any other comments or suggestions? Mirko?
Yes. I think that it is important. We thought about our cases of web. We had dilatated dilated proximal duodenum, but in case we don't found a dilatated duodenum, we thought to the positioning about the web of a balloon. So with endoscopically, so the traction of the balloon pull the web, and you can see the base of the web under a robotic or a laparoscopic view. So we perform this in the also in the case previously presented, and we saw that there is a part of the duodenum that pull up when you pull up the balloon. So in their point, you can find the limit of the web. I think I think an help that can be a good trick, but don't know because I have a dilatated proximal digiunus, so I was very happy when I saw that.
Yeah, sure. There's a comment from Dr. Catania. The main impression is that robotic approach combined with endoscopic allows a good visualization of the duodenum, and at the same time it guarantees a good instrumental mobility. Yes, it's true. Though it was not even easy to find the proper location of the cyst, even with endoscopy. But of course, I mean, without we would have not opened the duodenum, certainly.
But the problem with the endoscopy is that you need some insufflation. So if you insufflate the bowel, you will lose the space that you operate. So it's not, of course, it's it looks that it may be very helpful, but to have a good endoscopic view from inside, you need to have a good insufflation. So if you insufflate, all the bowel will become distended. So probably you will lose the space. So it's not.
Marius, I wanted to comment on this because we do a number of rendezvous along with the endoscopist for the gallbladder cysts and gallbladder stones. And they train me with the other surgeons to use a clamp on the trites ligament just to avoid the air to go down. And so you can do the endoscopy without having the air filling the bowel downwards, downstream. And you can do, it's not an elegant, but it's an effective endoscopy without too much air going down.
Perfect. This is, what I always take from such a meeting, some small trick that may be very useful. You can use it if you are in need. That's a perfect idea. Thank you.
Paparella?
Yes, just it's a very simple question. You have done the cholangiography post-operative. You advise this on all of these patients, or because you had some doubt about the procedure?
The second, Alfonso, the second.
Right. Okay.
Okay.
You were tightened than a duck has.
Yes. Okay, thank you very much. I think we can move to the next presentation from Bologna, Tommaso Gargano, who's going to tell us about congenital duodenal atresia and or duodenal stenosis, surgical rare cases. Tommaso, are you there? Probably
Yes,
not.
thank you. No, yes,
yes.
thank you, Valerio.
Oh, yes.
Thank you, Valerio.
Thanks,
Sorry.
Tommy.
Okay. Let me share my screen. One moment. This, so, okay. No. One moment. Because the same problem of this morning, but okay. Do you see my presentation?
Yes, Tommy.
Okay. One moment. Okay. Thank you again. Good afternoon again. My second presentation is about, I will present some surgical rare case relatively duodenal obstruction, in particular in newborn, in infant, and in adolescent. So this morning we saw the lab classification, the characterization of intrinsic obstruction and extrinsic obstruction. These cases that now I try to describe are almost extrinsic obstruction. So a case of annular pancreas, periduodenal portal vein, aortomesenteric compass, and a Let's band in intestinal malrotation too. So the first case is the case of Julia. Julia is a female of 2 months that born with a prenatal diagnosis of congenital heart disease. In particular, she was affected by left isomerism and obstructive aortic arch, the coarctation of the aorta in particular. And she underwent by cardiac surgeon, our cardiac surgeons, to the reconstruction of the aortic arch, creation of aortopulmonary windows, and atrioseptostomy, and the bending of pulmonary artery. Our management at the beginning was the feeding, and she present the feeding intolerance at 1 month of life, and the ultrasound for the feeding intolerance and this dyspepsia during the male. The abdominal ultrasound excluded the hypertrophic pylorostenosis, but showed anomalous course of the portal vein that appear arching above the distended proximal duodenum. So this is a case of duodenal stenosis, an extrinsic duodenal stenosis, secondary due to a pre-duodenal portal vein. We performed an upper gastrointestinal contrast study that showed an abnormal anterior and high duodenal position, like malrotation, and a narrowed string-like passage of contrast through its lumen, very important stenotic. So, intraoperative, we found the portal vein that passing anteriorly of the duodenum. So, we will perform, in this case, the bypass surgery, in particular side-to-side diamond-shaped duodenostomy according Kimura. You can see the horizontal, the transverse incision in the pouch, proximal pouch, the distal, the longitudinal distal incision in the distal pouch. And you can see the anastomosis, the diamond-shaped anastomosis. The second case is a case of Carla. She's a baby female 1 days that born with a prenatal diagnosis with duodenal obstruction, probably atresia. The symptoms were feeding intolerance and vomiting, and our management was fasting and insertion of nasogastric tube. The screening of the others associated anomalies was negative. This is the intraoperative finding. We identified the annular pancreas in the second and the third portion of the duodenum, and in this case we performed the open diamond-shaped duodenostomy too. This is another case of lead band in malrotation, so a duodenal obstruction secondary to a lead band, treated by lead procedure. This is a male of 4 days, Homar. You can see the contrast study, and that showed a suspicion of malrotation, and the lab procedure that consisted by identification of the anatomy. The cecum, for example, was under the liver, and the colon was located to the left of the patient. The small bowel was partially volvulated, but without signs of ischemia. The adhesion between the cecum and the duodenum were resected, freeing the cecum and positioning the cecum to the left of the patient. Mesenteric fan was opened to allow the jejunum and the ileum to be positioned to the right of the patient and the colon of the left. So this is the intraoperative find, the lead band between duodenum and jejunum. So you can see, and the cecum, sorry, the lead band. We can see the resect, the dissociation and the resect of the adhesions and the open of the mesenteric valve. So you can see we will perform a complementary appendectomy, and this is the final position of the viscera with the small bowel in the right side and the colon in the left side, freed of the lead band. This is another case of a male that presented a lot of associated anomalies, duodenal obstruction, anorectal malformation, congenital heart disease, and renal anomalies, like Vacterl anomalies. He born with by prenatal diagnosis of duodenal atresia, and at birth we found an imperforated anus. So you can see the double bowel, the double bowel signs. The cardiologic screening showed documented a ventricular septal defect and a patent foramen ovale. And the ultrasound showed a bilateral hydronephrosis. So this is the finding, intraoperative finding. We correct, we repair in the same procedure the duodenal atresia type 3. So by isolating of the upper inopen, upper pouch and distal pouch, and we performed the diamond shape duodenostomy according to Kimura. We performed also the Bianchi's anorectoplasty via abdominoperineal approach for this recto-urethral fistula, and we founded the Meckel diverticulum that we removed it. This is the last case, is an adolescent female, Nicole, that with a prenatal, sorry. This is Tanya. It's Tanya that she's had a prenatal diagnosis of duodenal atresia, confirmed at birth by X-ray with double bubble signs. No associated anomalies, and this is the case that we treated and we saw, and you saw this morning during the treatment, video assisted treatment of duodenal obstruction. You can see the open step with the sterilization of the second portion, the first and the second portion of the type 1 with the mucosal web of the duodenum, and diamond shape duodenostomy. This is a last, Nicole, a last case. She was she's an adolescent that was well-being up to 13 years of age, and she presented in emergency department for abdominal distension, dyspepsia, vomiting, anorexia, and constipation. The abdominal X-ray showed a gastric distension with hair fluid level, coprostasis, dilatation of small bowel loop with hair fluid level in the right flank. Our management was fasting and the nasogastric tube at the beginning, and we perform a ultrasound that show a reduction of the distance between the aorta and the superior mesenteric artery, 5 millimeters, with the interposition of the duodenal loop, which is compressed by this artery. So this is a case of aortomesenteric compass, or called superior artery mesenteric syndrome. We performed a CT scan that showed a reduced contrast enhancement of the last portion of the duodenum and the first part of the jejunum with diffuse edematous wall thickening that reduce significantly the viscera lumen. So we performed the contrast study that showed a dilated gastric cavity without progression of contrast behind the duodenal C loop. So after the diagnosis, our management was the catheter, the central venous catheter for parenteral nutrition, and initially watch and see. So after 6 days, Nicole was discharged in good clinical condition, but she was readmitted for ongoing symptom after 2 weeks. In fact, we found intraoperative, we found that we identified the superior mesenteric artery that compress the fourth portion of duodenum. So we performed a Ru and U duodenojejunal bypass, and you can see the preparation of Ru loop and the first anastomosis, side-to-side duodenojejunal anastomosis with Ru loops, and the second anastomosis and two-side jejunal anastomosis. You can see the closure of mesocolic windows in order to avoid the internal hernias, and at the end you can see the two anastomosis, the duodenojejunal and the jejunal anastomosis. Thank you very much for your attention.
Thank you, Gargano. A very comprehensive series of interesting cases. Comments from the audience?
Thank you, Tommaso. The last case, we almost had the same case as you presented, the last one. It was 17 years old boy who within 2 or 3 months lost a lot of weight, and suddenly he developed the same symptoms like compression of the distal part of the duodenum by mesenteric artery. And we even found at the literature that this is one of the complication of sudden loss of the weight. He's still awaiting for the surgery because he was very unnourished, in a poor condition. So we decided to put him on TPN. Then we started with nasogastric catheter, and he is doing right now fine because he is on oral feeding without any symptoms, of duodenal obstruction. So we are still waiting whether it will improve or not. If not, probably we'll go with the surgery. I don't know still whether this is a Ro Y bypass or just side-to-side anastomosis. We will decide, but this is just indication what you did. Probably we will consider it if the patient will come back to our department. And also very interesting was the case with duodenal atresia and anal atresia. I cannot recall such a malformation. Of course, I remember the baby with Down syndrome who had duodenal obstruction and Hirschsprung disease, but cannot
Yeah,
recall with.
but no anorectal. Yeah.
And just let me know whether you repaired it at the same procedure or it was in stages repair. How you did it?
The same procedure, the same procedure. And regarding, thank you for your first comment. I think that the first, it's very useful at the begin, the catheter central line for the parenteral nutrition, because the loss of weight is very the cause of in this patient of the superior mesenteric artery syndrome. And the second case that the pluriassociation of anorectal malformation with fistula, recto-uretral fistula, duodenal atresia, Meckel diverticulum, and renal anomalies is an abortive form of Vacter without esophageal atresia, without because he has cardiac heart disease, congenital heart disease too. So I think that and we will perform in the same procedure the repair of this association. So it's a particular case, so we wanted to describe.
And what was the cause of bilateral hydronephrosis? It was neurogenic bladder or posterior valve or what was?
But I think just hydronephrosis, but don't pathological in the follow up, and now is in the follow up too.
Okay, perfect. Thank you.
Nothing.
Darius, just a question. I mean, we've seen you operating a TOF today, and we've been talking about duodenal atresia. What's your policy in a patient with esophageal atresia and duodenal atresia?
That's interesting question. That's interesting question. We collected 12 cases that had together the duodenal atresia and also esophageal atresia, different type of esophageal atresia. So it depends how to manage such patients. First, usually we try to do to close the fistula, because if you have a duodenal atresia, there is a lot of secretion from the stomach going to the airway. So first to do is just to close the fistula, and if it is possible, just to make the anastomosis. Then you have a nasogastric tube, so you can evacuate. I remember the first case that I did in one stage, I mean, on the same procedure, but it was very, very long. So right now, what we do, first we repair esophageal atresia, and on the next day or in 2 or 3 days, we repair duodenal atresia. Duodenal atresia is not an emergency. No, you can wait. It's not a problem. So you can stabilize the baby and then you can repair. But we also had a long gap, I mean type A of esophageal atresia. So in this case, we first did the duodenal anastomosis. We decompressed the duodenum, and then in stages we repair esophageal atresia. So it depends on the type of malformation, but usually what first we have to protect the airway, so probably the closure of the fistula is the most important, because in other way everything goes through the airway. Yeah.
Thank you so much. If there are no other comments, I think we can give the floor to Mirko and his International Pediatric Life Surgery Online Group News Corner.
Yes, I try to share. Okay, my video. You can see the page, the internet page of LinkedIn. and very happy to show you our follower that reach more than 500 follower. 2 day ago, 2 months ago, I show you there were 300 more or less follower. Then we increase of 200 followers in 2 months. And other 488 connection. Then we increase day by day, and the country that want to connect and want to follow our LinkedIn page is worldwide, but the best part from South America, from North Africa, from India, from East Europe, and from Spain, and from the Middle East. So other connection and followers are Italian, some other European, but the most part of the follower are worldwide. We fail to have USA connections. Don't know why, but for these results, I'm very happy now, and I'm very proud to, and I hope the connection and follower grow day by day. I receive many requests of connection, many requests or follower, and I'm very happy. Every day, 2 or 3 connection requested in my email. So thank you for all the team that work for these results. Thank you very much.
Thank you, Mirko, for your efforts. It's really great what you are doing.
There's a Dr. Gabriel Anthony Villa from Philippines. He says that he's representing Asia. That's
Perfect.
great.
Great.
Perfect.
Darius, I think we are done. I mean,
Yeah.
it's up to you.
I would like to ask Mario. Mario, are you connected?
Yes.
Okay, perfect.
Yes, I am connected. Okay. We are finished.
Yeah.
The day we finish early, but it's best because sometimes we finish too late. I remember to my president that in July or in September is important to do the General Assembly of our group. And if the president and the committee agree, I send the communication to the whole mailing list, not only the participant. If you agree, or if you prepare, I send the mail all to the participant. For me, it's important that all know what is the goal, what is the program of our group. President, what is your opinion?
Mario, yes, we have to have such an assembly, so it's okay whether it's in July or September. It depends on people. So just send an email. Please send the email. We have to discuss our further topics for the next meetings and what we will do in the future. And of course, just after today's discussion, we have to prepare the certificate and to announce people that they can get the certificate after each meeting, but they have to be our members, So just do you have any graphic who can prepare such a certification, or just we can do it very simple, just with the logo of our group and nothing more, just to certify that someone has attended our meeting? What do you think?
Okay. And for the next meeting, the date is the 8th of October, exactly?
Yes.
Okay.
And
Thank you very much.
Thoracic surgery. What's the next topic?
The next topic is the surgery of the appendix.
Okay, perfect. So probably we
I
can
think
connect
is
a lot of cases.
yes, there is many topics and many presentation, and
I promise you, if we have a duodenal atresia, duodenal obstruction, I will show you in live surgery. So just even that we didn't have today, the next case I will show you. Okay.
But for the all colleague that is connected, there is the last minute meeting that is possible if you have particularly procedure to show. And on the website, there is the page of the last minute library with the video of this is ready. For the general meeting, Darius, I think that is better July if it is possible for you and for the whole members, because in September probably there is a Congress. In July, I think as we have much possibility to see it, to have a good date. Okay.
Okay, perfect. Maybe in the middle of July, is it okay for you?
Oh yes, for me it's good. For middle of July for the whole committee and okay.
Okay. So just thank you very much. A lot of people attended our course. Still, we have 88 participants connected. So thank you very much. Really very great day. A lot of discussion, a lot of knowledge. So thank you very much once again, and see you during the next meeting. Thank you very much.
Thank you.
Bye bye.
Thank you.
Bye.
Bye.
Bye bye. Bye.